Today we'll be reviewing special techniques used in blood banking. These are the techniques we'll be going over in this lecture. Enzymes are used to treat red cells. They can be used to enhance or destroy the activity of an antibody in testing. This allows for confirmation of an antibody or can remove interference to allow for detection of other antibodies. These are the most common enzymes used in blood banking. Papain comes from papaya, physin comes from figs, bromelain is made from pineapple, and trypsin is made from hog stomach lining. This slide you will want to commit to memory. These are the blood group antigens that are enhanced, decreased, and unaffected by enzyme treatment. In the enhanced category, you have ABO, Lewis, I, P1, RH, and KID. So remember, most of your carbohydrate groups are enhanced by enzyme treatment. Decreased are MNS, Duffy, Chido-Rogers, and Lutheran is only affected by trypsin. So physin does not affect Lutheran. And Kell system is unaffected by enzyme treatment. So how do enzymes work? Remember what the surface of an RBC looks like. Enzymes will remove sialic acid from the RBC membrane to make antigens more accessible. It removes glycophorons, which includes the MNS system, and it will enhance the reactivity of autoantibodies, cold and warm. You should always run untreated and treated cells side by side so that you can compare the reactions. Now we'll go over an example. You can see here a patient was ran with untreated cells and physin-treated cells, and there's some extra reactions in the untreated cells. So note in the untreated cells that there's different strengths of reactivity. Also note that the physin-treated panel, you lost a lot of that weaker reactivity. You can see in the physin-treated panel, you still have two reactions. So we want to look at those cells and see what they have in common. Cell 12 and cell 22 are both positive for the Kell1 antigen. And you can see the cells that lost their reactivity with physin, cell 13, 15, 16, and 20, are all positive for Duffy A antigen. Remember which antigens are destroyed by enzymes and which antigens are unaffected or enhanced. Remember, the ones that are destroyed by enzymes, you cannot use those for antibody rule-outs. And big S and little s do give variable results with enzyme-treated cells. Moving on to sulfhydryl reagents. DTT and 2-ME are the two most commonly used sulfhydryl reagents. They work by cleaving the disulfide bonds of IgM molecules, eliminating the antibody's ability to agglutinate red cells or bind complement. Reducing the disulfide bonds on IgM molecules decreases their polyvalency and ability to directly agglutinate the cells. Treatment of plasma or serum containing a mixture of IgM and IgG antibody with sulfhydryl reagents eliminates the reactivity of the IgM antibody. You can also use these reagents to treat red cells. When treating red cells, the reagents will cleave the disulfide bonds that are responsible for maintaining the conformation of some antigens on the red cells. This will disrupt the tertiary structure of proteins by irreversibly reducing the disulfide bonds to free sulfhydryl groups. Without that tertiary structure, protein-containing antigens can no longer bind antibodies that are specific for them. Kell, LW, Cartwright, Dombrock, and Knopf system antigens will be denatured or weakened when treated with sulfhydryl reagents. KX will not be destroyed, it will actually be enhanced. Keep in mind DTT is a component of some other blood bank chemicals, including ZZAP. Using DTT-treated cells are one of the methods we use when we have suspected high-frequency antigen. There are many high-frequency antigens in the Kell blood group system, and DTT removes the Kell blood group system antigens from the surface. So these can be helpful when you're suspecting one of those high-frequency antibodies. DTT-treated cells are also used when we're working on a DARA workup. DARA is an anti-CD38 monoclonal antibody drug. DTT also destroys CD38 off of the RBC cells, so this is a very helpful method for dealing with this drug interaction. This is a very helpful chart if you have an antibody that's reacting in a way and you can't really pinpoint what's going on. You can use these different methods and then kind of narrow down what your options could be. Okay, moving on to titration. This is a method used to determine the highest dilution at which agglutination can be detected macroscopically. We use this in prenatal studies, sometimes in antibody identification, but not very often. Titration is considered semi-quantitative. It can determine the relative strength of an antibody, and the titer is reciprocal to the highest dilution with a 1+ macroscopic reaction. This is important because if you have a weak plus reaction, you're not going to consider that your last reaction. It has to be the 1+ reaction. Consistency is very important between techs. At this level, different techs have different reading methods. So it's very important that everyone is reading that 1+ reaction at the same level. For prenatal studies, we will titrate a maternal IgG antibody to make sure that the HDFN isn't progressing. If the titer keeps increasing, then the doctor may want to start using other test methods to actually make sure that the fetus is doing okay. Sometimes titers are performed on what we call high titer, low avidity antibodies. This term isn't really used anymore, but there is a group of antibodies that have a very high titer but low avidity. So usually these are not clinically significant antibodies. Okay, neutralizations. This is performed when you have an unknown antibody and a known antigen. And usually the antibody is not completely unknown. You're suspicious that it is one antibody, but you're going to confirm with the neutralization. And then you can also use the neutralized plasma to complete your antibody ID. So these are some examples. Notice these are mostly antibodies that are not clinically significant, and they're kind of just nuisances. So you can neutralize these so that you can continue and rule out all your clinically significant antibodies. So saliva with known Lewis substance can neutralize Lewis antibodies. Pigeon egg albumin will neutralize anti-P1. Pooled plasma will neutralize the Chido-Rogers antibodies. Human milk will be positive for the I substance, so it can neutralize anti-big I. And then pooled human urine can be used to neutralize anti-SDA. This is not a common one that you see, luckily. So we're going to use anti-P1 as an example for this. So we think the anti-P1 is in the patient's plasma. So we're going to use the known neutralizing substance, incubate it with the patient's plasma. If it's present, then the antibody is going to be neutralized. So you're going to add your indicator cells, and there's going to be no agglutination. So this indicates that the antibody has been neutralized. So you'll have your indicator cells, which would just be screen or panel cells that are positive for P1. So before neutralization, they're going to be positive for all the P1 cells, and then after neutralization, they're going to be negative for all the P1 cells. So that confirms that anti-P1 is in that plasma. Agglutination inhibition is kind of similar to neutralization. It's a principle that's used in secretor testing. You have a known antibody and it's incubated with an antigen. So when you're doing secretor testing, you're trying to determine if this person is secreting the antigen, and it will be found in their saliva. So you'll take a known antibody, such as anti-A1, incubate it with the person's saliva, and it will neutralize the antibody. If the person does not have that substance in their saliva, then the antibody will still be free. So then when you add RBCs that are positive for that antigen, it's going to agglutinate. So in this case, a positive reaction is actually a negative reaction. It's very confusing. You kind of have to just think about it to wrap your head around it. But if you see agglutination, that indicates the absence of that antigen. Okay, elutions. This is a process of removing antibodies from the surface of sensitized red cells. The antibodies are recovered in a concentrated form and used for subsequent identification procedures. So we have Louis freeze, which you would use for ABO investigations, and acid elutions that are used for warm reactive allo or auto antibodies. And there are commercially available kits such as the gamma elu kit. So what happens during an elution? You have antibodies coating some RBCs, and you're basically just eluting those antibodies off of the RBC so that they are available to test to determine what those antibodies are. Elutions are performed pretty regularly in the blood bank setting. They can be used to investigate positive DATs in cord blood workups and will assist in the diagnosis of ABO, hemolytic disease of the newborn, or IgG, HDFN. We also use them in suspected transfusion reaction workups. And if a patient has a positive DAT, we can elute the antibodies off the cells so that we can actually phenotype their cells. Adsorptions are one of the more complicated procedures that we perform in blood banking. It's important that you understand the terminology here. We're performing adsorption, not absorption. So think of absorption as like a sponge. You're soaking up substances. We're not doing that. We're doing adsorptions. So we will take a known RBC that has a, say, Duffy A antigen, and if we want to get the Duffy A antigen out of the patient's plasma, we'll incubate them together. That anti-Duffy A will adsorb onto the adsorbing cell and leave that plasma free of the antibody that we're trying to get rid of. So this technique can be very helpful whenever you have an antibody to a high-frequency antibody. You can adsorb that antibody out so that it will leave any other allo antibodies so that you can continue to rule out all the common antibodies. There are three main adsorptions that we perform: auto, allo, and then a differential adsorption. So auto absorptions are when you're using the patient's own red cells to adsorb out. The key for this is the patient must not be recently transfused. If the patient's recently transfused, then the donor cells are mixed in, so it can absorb out something that you don't want it to. So for allo adsorptions, you must know the patient's phenotype because you want to select a very closely matched phenotype unit to adsorb out. So the key for this one is you must know the patient's phenotype. So here's an example of how you could use allo absorption. You have the patient's phenotype, and you think that the patient has anti-Duffy A and anti-little s. So you can take a selected cell that is Duffy A negative and S positive, and then that's going to take all the anti-little s out of your plasma. So then you can do some more panel testing to confirm that it was indeed anti-little s and anti-Duffy A, and that should give you more cells to perform rule-outs with. So here is the panel results before adsorption. You can see that almost everything is positive, so you only have one rule-out cell. So here you can see cell 21 is the only negative cell. So that adsorption took out all the anti-little s. So now you're getting some negative results. So you have more rule-out cells that you can use now. You can see now it's only the anti-Duffy A that's reacting. So we confirmed that it was anti-little s that was adsorbed out. We confirmed that the anti-Duffy A is still reacting, and we have enough rule-out cells to rule out the rest of the clinically significant antigens. So differential adsorptions or when you use 3 different phenotypes to adsorb. This is really the only adsorption you can perform when you do not know the patient's phenotype. So you don't know what to adsorb with. You can't select a pheno-matched unit to adsorb with because you don't know what the patient's phenotype is. So basically, you want to pick 3 different cells that will cover all the basic antigens so that you can rule out any clinically significant antibody. There's also the rabbit erythrocyte stroma adsorption. These are used for cold antibodies. There are some downsides to this. Rabbit red cells are positive for the B antigen, so you cannot use that adsorbed plasma for ABO typing because any anti-B will be pulled out of the adsorption. Okay, pre-warming is a technique we might use whenever we have a cold agglutinin that's getting in the way. We might use this to resolve some ABO discrepancies, but we have to be careful because there are a couple of clinically significant antibodies that can go away with pre-warming techniques. So rouleaux usually presents itself as a kind of weak reaction that doesn't really make sense. If you look at it under the microscope, you'll see a stack of coins appearance in the cells. This happens due to an abnormal protein concentration. So this is really thick plasma, and it occurs in these patients listed here. One thing to note about rouleaux, you will never see rouleaux in AHG testing. If it's really, really bad, you can see it in immediate spin and 37 degrees, but you will never see it in AHG. So to perform the saline replacement, you'll first confirm under the microscope that you see that stack of coins appearance, centrifuge the test again and remove the plasma, and then replace the plasma with 2 drops of saline, mix well, centrifuge again, and read it again. If it's true agglutination, then it will still be positive. If it's just rouleaux, then it will be dispersed by the saline replacement and it will be negative. Remember, it's only seen at immediate spin or 37-degree incubation, never at AHG. So we covered a lot of topics in this lecture, so just let me know if you have any follow-up questions, and then hopefully we can apply some of these in our future labs.